Hello, everyone. As Maureen said, my name is Alyssa Alter, and I'm a member of the Board of Directors for CNETS. I'm really pleased to be here today, primarily as the introducer of our next speaker, Talar Boyajian. Talar is representing Dr. Deanna Midmer, who is the lead investigator for our project, but Deanna is not able to attend today. Talar is a graduate student at the University of Toronto, pursuing a Master of Science degree in the Department of Health Policy, Management and Evaluation at the University of Toronto. Talar will be assisted by Armin Paragamian, who is a medical student at the University of Western Ontario, graduating class 2010. I had the pleasure of working with Talar and a small group of NETS patients and caregivers on a project that at the beginning we affectionately called our Patient Voice Project. This name, while simple, seemed very appropriate at the time because we all knew from our own personal experiences with this disease that there were many patients in our community whose voices needed to be heard regarding their experiences and their frustrations with misdiagnosis. In the past year, Talar and Armen have been instrumental in organizing the results of our project, and together with Deanna Midmer have shaped it into today's presentation. Please join me in welcoming Talar and Armen.
Thank you, Alyssa. Good afternoon, everyone. I just want to say, although we are presenting, there's been many others who have been involved in this research, so I just want to take a moment to point them out. Everyone knows Maureen Coleman, and there's also Dr. Bates, Carol Bates, and Alyssa Alter in the back, and Jim Kormos, who's not here right now, but he was also involved, and lastly, Diane Roteau.
So we'll sort of, the pace at which we go is unfortunate because we'll speed it up in the name of time. We could take a long time because we're very passionate about this topic, but in the name of time, we'll go quickly here.
Okay, I just want to say that you heard that Armin was graduating from med school this year, and I will actually be starting med school in September, and I know that awareness in the medical field is a big thing for the NETS community, so I'm happy to say we will be 2 more doctors in the field that know about NETS and are working to improve the system so that patients receive the best care that they can, that our system affords. Okay. So patient and caregiver perspectives on the difficulties diagnosing and treating carcinoid neuroendocrine tumors, a qualitative study.
Cool.
Yeah. So,
can we go back one? There we go.
Conflict of interest. This study was financed by an unrestricted grant from CNETS Canada. Traveling funds were graciously donated by Lawson Foundation, and no pharmaceutical funding was received. What are NETS? I'm going to just skim these because we've gone through them at length this morning. So we all know that NETS are developed from cells of the neuroendocrine system, which can be found throughout the body. And the most common type of NETs are carcinoid tumors, and they can either be functioning or non-functioning. The functioning ones can yield carcinoid syndrome.
Once again, we've gone through this as well. The slide should read incidence and prevalence. The incidence rates are listed here. They're from 2003, so over the past 30 years, the incidence rate has been increasing, and so these numbers may underestimate the incidence rate. It's said that by 2012, the incidence could be as high as 8 cases per 100,000 in the population per year. Currently, the prevalence is about 35 individuals per 100,000. And the increase in the incidence can be largely attributed to better diagnosis and the increasing age of the population. Treatment of NETs, much wiser people than ourselves have discussed this at great length, so we'll humbly skip this.
So purpose of the study. Our main purpose was to explore patient experiences, both their personal experiences and their medical experiences with their diagnosis and treatment of their NET. as well as to explore their caregiver experiences while they were caring for a loved one with NET.
So essentially the hope of the study is to identify potential areas for improvement in the comprehensive care that NETS patients receive. We're hoping that the project provided a voice or an outlet for patients and also serves as a mechanism to give healthcare providers a bit of feedback about the care that we're providing. So,
the methodology. 3 focus groups were used. 2 of them were patients and 1 was of caregivers. And participants were chosen from the membership list of CNETS Canada. And ethics was approved from U of T. We used a pre-interview to really determine the suitability of our participants. We tried to determine whether they were articulate, whether they could comfortably speak about their experiences in this setting. A professional focus group facilitator donated her time, so she volunteered for us. And with her help, we developed an interview guide with both specific and general questions about their experience with NETS. Sessions were held in a boardroom with a one-way mirror and were audio taped. Myself and another note taker took notes behind the mirror. And then we also took the audio tapes and transcribed them fully, and these were all held securely at U of T. So once we had the audio tapes and the transcriptions, we used a constant comparison strategy. 5 reviewers read the transcripts and developed the themes, and we discussed as a group to reach a consensus on the most important themes. So this is our patient demographics that we found. As you can see, there was a variety of NETs that we purposely tried to include in the group. And also, if you look at the years from signs and symptoms to diagnosis, it seems to be bimodal. Some of them, about just over half of them, were diagnosed within a year, which is good, but unfortunately some of them, it took over 20 years for them to be diagnosed.
So what we did, as previously mentioned, is we took the audio tapes, and once they were analyzed, we drew from them the most significant themes or recurring themes that patients had stated as being very important to them. We broke it into categories, and those can broadly be defined as the patient's experiences themselves, the caregiver experiences, issues that patients raised about the healthcare system or issues that they perceived being systemic in nature, and then issues that patients raised about their physicians. So we'll sort of go through these as quickly as possible once again, and we'll just have a couple quotes to sort of illustrate some of the things that patients actually said. And here we are. So the first category here is patients and the subheading misdiagnosis or difficulty in diagnosis. Patients sort of overwhelmingly stated a certain amount of frustration with the time it took them to reach a diagnosis. This is, and not only the time it took them to reach a diagnosis, but the number of physicians that they consulted in the road to reaching a diagnosis. Some saw GPs, endocrinologists, gastroenterologists, and a certain amount of time elapsed before they were able to come to a diagnosis. Of course, as a result, largely because of the indolent nature of the tumors and the vague symptoms. But patients really were frustrated with the fact that the elapsed time resulted in a more advanced disease when finally diagnosed, potentially more advanced disease when finally diagnosed, and of course, earlier diagnosis portends better prognosis. So,
the biggest difference between NETs and other cancers is the time to get diagnosed. If they had diagnosed it earlier, my symptoms would have been much less, and I would not be as sick. I had several doctors and tests for over 10 years. Most people don't find out the tumors are there until they've grown and spread. You're at a point that it's too late.
All was not negative, one patient did say.
I had a positive experience. From the time I was diagnosed and seen by a specialist wasn't long. Maybe it's because my doctor had seen this before and knew what steps to take me through.
Second subheading is financial distress. Of course, as with any cancer that can be quite debilitating, patients found it hard to keep a job while experiencing flushing and diarrhea. This, of course, pertains specifically to patients with functioning carcinoid tumors and carcinoid syndrome. Considerable travel time was also needed for a majority of these patients to get to treatment centers that were at quite a distance, and this we'll talk about a bit later in terms of centers of expertise. And sick days were soon used up, and time off work as well.
I had to stop working. I wasn't planning to retire, so it caused financial strain. People I've seen with colon cancer were off 6 months and go back, but I can't. I lost my job, had to pay for drugs, no disability money from the government, and no CPP. All in all, I lost everything.
Uncertainty was a big factor here as well. A lot of patients felt that it was difficult to predict the progression and prognosis that their disease had, and in that regard, that made making life decisions very difficult. So planning, whether it be vacations, family planning even, these things had to be put on hold until the patient could get properly diagnosed, properly worked up.
My doctor said 6 months or 10 years. You're left unknowing. You're not able to plan anything properly. I'm not getting pregnant until he gets stronger. If I get pregnant, I don't get paid if I don't work.
Poor quality of life, of course, this applies to all cancer patients, but I think that it has a special meaning for that subset of patients that are suffering from any particular endocrine symptomology, such as carcinoid syndrome. You can't make plans, you can't leave the house, and the other issue is neuroendocrine tumors can be a sort of a long-term thing, as we've discussed with their indolence. It's something that's protracted over the long term, so patients' quality of life is sacrificed over the long run.
This is draining. I'm tired all the time. It hasn't affected me until now. I've been lucky. It's comforting to know I have a certain amount of time. The last 8 years have been the best years of my life. This goes on and on and on. Not one surgery and you're over. Every day it gets worse and worse. There is no cure like other cancers.
Loneliness, because of the different net manifestations, there's a lack of commonality in signs and symptoms. So there were actually a number of patients who said that they didn't have the same sense of unity as you would find potentially in other cancers. Although there was general support in the form of Carcinoid Neuroendocrine Tumor Society, they felt that they felt somewhat isolated in terms of specific support for their symptomology or their particular tumor. And there's a lack of understanding sometimes on the part of family or the general public because of the rarity of the disease itself.
You work very hard to appear you don't have a disease. I don't want people to feel sorry for me. Other forms of cancer are well publicized, run for prostate, breast cancer, etc. But NETs, nobody knows. It's a shame it's not acknowledged. It's like you're not really a cancer patient. Oh, so you have this odd thing.
The role of support groups, as can be imagined, support is very important for any cancer patient. Some found it very positive, and others found them somewhat less so. It was important to talk about the disease freely and discuss new treatments and procedures. And actually, many people attended these sessions to learn about different treatments, local, regional, national, and even international options that they might have had.
I don't go. I don't want to spend time thinking and learning if my tumor is going away for good. In some ways, I want to be better educated, but my life is bursting at the seams with a full-time job and a husband who travels.
Comfort and faith.
I don't know how people deal with any of this if they are not grounded in faith. You just carry on by the deep, abounding faith that can do wonders.
The role of caregivers, as touched on previously, provide emotional, psychological, and even physical support at times. They also act, they play many roles. They also act as sort of medical experts. They become very knowledgeable on the disease, often doing a lot of research. They also act as a patient's advocate in terms of access to resources.
Nope. Oh, can you go back? They also act as family buffers, answering difficult questions from family members. For example, is mom going to be okay? Is mom going to be around? I would find it almost impossible to go without my caregiver. After an appointment, I ask my son what happened. I get so tense. I don't remember the finer things. I couldn't go alone. I don't feel that I'm sharp enough. As a caregiver, you have to turn yourself into a researcher. My role is understanding the language. The patient doesn't hear everything. We try to back it up. You want to know what's going on, and you ask questions they don't ask or forget to ask if she is in shock or doesn't want to aggravate the doctor.
Now, the next subcategory was from the perspective of the caregivers. Emotional turmoil was a major major aspect of their lives after their loved one's diagnosis with a neuroendocrine tumor. Because of the long natural history of the disease, their lives changed dramatically over the long run. Fatigue, frustration, anger, many of the same feelings that the patient would have, the loved one obviously feels that as well with respects to treatment and
I have to change her to pens. She is going through 10 to 15 bouts of diarrhea a day. I went to my family doctor after a bad meltdown. It was like my husband was my baby when he first came home after surgery. I'm a pretty tough cookie, but having to work and being a primary caregiver, I was just so angry at this disease.
Now, issues with the healthcare system as perceived by the patients, a lack of funding. Because of the rarity of the disease, patients perceive there to be a lack of funding, and a very real one.
You don't get funding, you don't get research, you don't get cured. You get annoyed with all these fundraisers. I mean, I feel sorry for all those people with breast cancer, but we're dying from cancer too. We feel neglected. We are an orphan disease.
Technology and drugs. Because of the limited availability of certain drugs in Canada, certain patients with the financial needs sought treatment abroad, whether it was because of funding or drugs being approved or not. Smaller tumors, in theory, went undetected because of the lack of cutting-edge technology. Certain types of scans, ectopipette scans, that might have more sensitive imaging capabilities, patients might not have had access to or might have had difficulty qualifying for. And incomplete information on the extent of the disease can lead to inappropriate treatment. So, depending on their tumor status or their metastatic status, that played into some of our patients' treatments.
When I had a CT scan, they saw 2 tumors in Canada, and in Sweden they saw 10 tumors.
Lack of algorithms and protocols. A lot of patients perceive there to be a lack of a clear treatment protocol or universal treatment regimen. And they found this very confusing. Now, there are Canadian guidelines, American guidelines, European guidelines, but because patients have access to the internet and are all sort of in communication, this can be confusing for patients because they hear about other people receiving different treatments, and they were unclear as to why they were receiving a specific treatment algorithm.
I have a wife who has had both breast cancer and a NET. With breast cancer, there is a system, there's a process. You get diagnosed, have an operation, and subsequent chemo or radiation. But NETs are totally opposite. There's no path, no store with a sign that says NETs identified or treated here.
Issues raised about patients' physicians, lack of awareness or knowledge. Patients felt that many physicians at the primary care level in particular had limited awareness of NETs, and patients felt that need to go to Europe for care where there were designated centers of excellence that pertains to access to certain types of treatments or imaging modalities. And patients and caregivers wondered why Europe was far ahead in terms of their understanding, care, and treatment of NETs. And a lot of this, I think, patients understood is partially related to the rarity of the disease, but nonetheless is a very frustrating aspect of being a patient with a neuroendocrine tumor.
Lots of doctors don't even know what carcinoid syndrome is. I know more about carcinoids than my doctor. He asks me questions. One doctor told me that carcinoid was not cancer and that it was not malignant and that I shouldn't worry. Getting good care seems to be luck of the draw.
Physician resistance to information or research from patients. Patients felt that they had to advocate for themselves and had a more positive experience if their provider encouraged them to be involved in their decision making. Other patients found that their physicians were resistant to hear about new treatments or studies. Here's some quotes.
My doctor is teaching his students based on this case. He said if I find new material, would I deliver it to him? He wants his patients involved. If you bring them information, they say they don't have time to read the material.
Some patients felt that their concerns were dismissed. There were differing opinions about physician attitudes, of course, but some felt dismissed, and others felt that their physicians were quite compassionate and always listened to them, and they felt valued as a patient.
There is a lack of listening skills. That's what I'm getting big time. You're looked down at, not as an equal. My experience is different. The doctors I went to always listened. I found my doctor very caring.
Territoriality. There can be some reluctancy to offer follow-up care to patients who received care abroad. If patients were put on a medication regime while abroad, their Canadian physician would sometimes refuse to prescribe it even if the drugs were available in Canada. Some patients also found that their physicians were very receptive to alternative care ideas, of course.
I was told to stop taking my meds prescribed abroad and to try a trial. Why would I stop something that is working? I went to England 3 times. It was pre-approved by the Ministry of Health, referred by my doctor, and it was another positive experience.
Lack of patient education. A lot of patients felt that their physicians didn't spend enough time educating patients. The onus is on the patient to find out about their disease and possible treatments. Patients felt that without computer research skills, they were at a disadvantage in terms of access to resources on the internet, and the energy drain on patients looking for easy-to-understand information is quite considerable.
My wife will be online all night. If you're not that type of person, I feel sorry for you. You're on your own. Nobody cares. Someone says have chemo. Someone says it doesn't work for low-growth tumors. You just don't know what to do. I talk to 3 different doctors and get 3 different answers. Okay, so study limitations. This study was a relatively small study. More groups may have brought out different issues or different perspectives. And as well, all the participants actually were from Southern Ontario, so it's more limited in its scope. It's not a very national perspective. So what to do? NUTS needs to go mainstream. Continuing medical education is needed for all physicians, and although conferences like these are great, we really need to get to the physicians at the primary care level because they're the ones that are first seeing the patients when they present with the symptoms. Care algorithms and protocols need to be standardized internationally and disseminated. I think that that's the issue, is really disseminated to the patients or made aware to the patients because they really felt confused about the protocol, the care algorithms. As Armin said, we know that they do exist, but for some reason they're just very conflicting and they're just getting a lot of conflicting information. Oncologists and surgeons working with rare cancers, like NUTS, should be financially supported. Educational resources are needed for patients. Many of the patients told us that they did all their self-education on the internet, and this can be, as you can imagine, very overwhelming, sometimes difficult to understand if it's academic literature. And of course, it's a reality that a lot of doctors don't have the time to sit down and educate their patients extensively. So really, there's a need for very simple to understand information available to patients. And educational materials should be placed in family physician offices.
Patient navigators are needed to help clarify the therapeutic strategy for each patient. So a lot of patients felt that if there was a nurse case manager that could at least help them assimilate some of the multitude of information that they're facing, that might make them sort of more at ease. And also if there was someone there to answer some questions, some more basic questions that they couldn't ask their physician in their limited clinic time, that would be, a very comforting thing to have. Centers of excellence need to be developed in Canada that accept referrals nationally. Now, we know that we have Montreal and London, for example, that are centers of expertise or excellence. But like has been touched on, there's all this. There are funding issues and there are restrictions with up and coming with respects to accepting patients from other parts of Canada because of funding for this expensive treatment. But this is something that I think, like has been mentioned before, more eloquently, needs to be worked on such that patients anywhere in Canada can have equal access to these resources and not have to go to a different center. The flip side of it being this sort of silo cancer management that we, at the provincial level, where patients are getting diagnosed or treated or worked up or getting imaging in different places, and that can also sort of contribute to an already overwhelming process for a lot of these patients. Cutting-edge treatment, in terms of funding in Canada, cutting edge is obviously a delicate term to use. I think that a lot of patients felt that at least some of the things that they were getting done overseas should be funded on a compassionate care basis, which a lot of them are. But again, there's a lot of factors in terms of qualifying for that type of funding that are sometimes difficult to get. So things, for example, like radionucleotide treatments or F-DOPA PET scans, things like that that patients are getting overseas, need to be worked on in terms of funding. So
just thank you to Tanya Heinzman of Heinzman Research for focus group facilitation. Thank you.
that's that. Thank you.